Hello, everybody. Welcome to another edition of the EMS Case Studies. Today we are talking with Captain Jesse Murphy and Lieutenant Eric Jaramillo. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And thank you both for joining us today. I think today we're going to talk about a very prevalent topic in terms of interagency interactions when it comes to behavioral health calls. So I appreciate you both being here. So I'll start with you, LT. This call initially that we're going to discuss came out as a 25 Alpha.
Yeah.
You were assigned to Medic 12, and you guys were going to an apartment complex. Talk us through just real quick what's going through your head in terms of what you're expecting, what you're anticipating, some of the things you're thinking through before you get to a call that's coded as a 25 behavioral health.
Usually this part of the neighborhood was pretty rough. I'm not sure if they have always the capabilities to seek medical care constantly or someone coming. This one, whenever we arrived on scene, we were informed that his behavioral health, his caretaker, he was already angry with her and making statements to her. So saw that in the notes with from alarm.
You guys get there, you have your initial assessment, your patient, it sounds like they were alert and oriented. Did you guys have a dialogue when you first arrived?
He was already angry. At PD, she informed us that this guy has made these threats or whatever. Okay, cool. These threats were like, I'm going to get a gun and blow my head off. And we're like, okay. So we go in there and try to build some rapport with the patient. We ended up doing that. He's still angry, very loud. Admitting to him, he's like saying, I'm in a bad situation, da-da-da. And we're like, we know you're in a bad situation and this sucks. And I know you don't want us here, but we're here. Let us help you. And just trying to break down those communication barriers of letting him express himself with us and telling us what's going on. And he ends up telling us, he admits, I said those things and I'm going to do it. And just very certain that was going to happen. So
an articulated threat that he articulated not only to the officer, but to you, to saying, I have a plan, I'm going to kill myself, this is how I'm going to kill myself. So automatically at this point, we know that this individual is going to have to be transported for a mental health evaluation at a minimum.
Correct. Yeah.
Okay. As far as trying to figure out, because one of the key pieces for us to figure out is if there's a medical component associated with this, did he allow you to perform an assessment, check vital signs, et cetera?
Vital signs, no, he didn't let us. He let us do A&O questions and basically just count his respirations.
Okay.
And as far as we got.
Did he elicit any type of medical history, or it was basically shut down?
Yeah, it was kind of just a shutdown. He didn't want to tell us anything further about that. He didn't have any medical complaints.
And those are always tough because they're automatically shut down. Obviously, they're in crisis at that moment, so it's going to be difficult to have good conversation. It sounds like you did your best to create that rapport with him. So really, all you can go off now is your surroundings and your physical, visual assessment.
Yeah.
Talk us through, if you can, what you saw in the apartment on him that just help you clue into what he's going through right now.
Apartment was pretty much well kept. He didn't like that many people being in the room. And so 5-5 had showed up. So it was me, my student, the officer, and one person from 5-5 trying to talk with the patient. But the room, was pretty nice. As angry he was getting, we were thinking, I was like, have you consumed any alcohol? And he said, no, it's just ginger ale. I was like, okay, sounds good. But other than that, everything else seemed normal. Didn't see any weapons or anything. We asked the officer if she saw anything. She didn't say anything. So,
it sounds like you did a great job at this point. I mean, I think it's always important to remember that patients have autonomy. And this patient is a perfect example of someone who can prove to you that they're alert and oriented and they can understand what's going on. And they're exercising their right to say, no, you can't touch me, and no, I don't want to be assessed.
Yeah.
So,
and we'd encourage them you're right. You're alert and oriented. You've answered our questions. We don't have a right to do anything that you don't want us to do. Okay.
Absolutely.
Yeah.
And patient was wheelchair bound, we said, but we didn't really get into why or how long he'd been wheelchair bound, but he was in a wheelchair when you saw him.
Yeah, lots of profanity. Just
It's a tough situation. It's very common, unfortunately, a call that we all go to. So talk me through what the final disposition was. That he didn't want to be assessed. Was he willing to be transported to seek further evaluation?
He wasn't at first. We told him that due to those statements that you made, we can't just let you go. We can't just, by law, we can't just up and leave and say you're good to go. Mm-hmm. You admitted that you have this problem going on. How you get there, we could go with PD, go with us. It seems like he didn't really, we weren't getting a lot of from PD. I asked him about MCT. They said they kicked it back and they're not available. Okay. I'm not sure how MCT works, if that's something that regularly gets kicked back or different avenues. So we're like, okay, 5-5 have mentioned there's a phone number, that suicide
the 988 number
that they could call. But at that time it was just like, I didn't feel comfortable just leaving him, and neither did.
Absolutely. You did a great job. You recognize that this patient meets the involuntary emergency guideline, that he can't stay on scene. He needs to be evaluated by a physician, preferably a mental health eval. And that number, just to touch on that real quick, is that's a great resource, but it's not really appropriate for these kind of patients that are making credible suicidal threats. It's more for somebody who's, if they're feeling down or they're really kind of any mental health issue that it hasn't escalated to the level of threatening to kill themselves. Yeah. So you did a great job at this point. You've determined this patient needs to go to the hospital. And
we just felt like we were communicating better with him than the officer was. And at that time, it was just like, okay, cool.
Sure.
And like, even when we brought him the gurney, he's like, what the F is this for? And we're like, we need to help you get onto here. And he was like, I'll do it myself. Everything was, he wanted to be in charge. Sure. So I was like, all right, cool.
Yeah, understandable.
And this patient was able to stand up from his wheelchair and then sit on the gurney.
It was like a little stand and pivot.
Okay. Yeah. Awesome. Okay. That's important for later.
So ultimately, he was transported by Albuquerque ambulance, was able to stand up, move over to their gurney, was transported by AS. We'll fast forward. Now, a little bit later, you got the phone call just in regards as the quality assurance officer, just for some guidance and some input from Lieutenant Jaramillo. What was that phone call? What did you guys talk about?
Yeah, so after the patient had been transported, Eric reached out, which, thank you for doing that. That's big part of our job. We're just meant to be an additional resource for the crews, because these calls in particular have so much gray area. A lot has changed in the last several years, and so it's hard to keep up with the changes. And just to reiterate where we're at this point, is you did a great job determining this patient needs to go to the hospital. You did a great job, not forcefully assessing him. And the conversation we had afterwards, you had kind of asked me, hey, did I do the right thing? Should they have gone with PD? Yeah. Looking for guidance. And that's really the point of why we're here today, is to communicate to everyone else that, for a patient like this that is alert and oriented, that they're suicidal, and they need to have an evaluation. You did a great job doing that. So the next step is to determine if they have any medical component. And this patient clearly did not have any medical component. He did not think he did. He didn't want you to medically assess him. Yeah. And that's so awesome. So we've checked all those boxes. The next one is to determine, hey, would this person be appropriate to sit in the back of a police car? APD has said that they want to own the behavioral health program. And so part of that is that if we have any psychiatric patient that's experiencing a mental health emergency, that APD is supposed to be transporting these patients. They have complete authority, they have complete responsibility for these patients, apart from a medical component. So this would be a great patient that APD often, they want us to transport, but a patient that can stand and pivot, he's not always wheelchair bound. He uses it for his primary means of mobility, but he can stand and sit. So this would be an appropriate patient to put in the back of a police car and transport to mental health. That's a preferred way at this point. And this obviously takes good interpersonal interactions with APD. A lot of them, there's been changes too on their side. And so I find it's helpful to take the memo, the most recent memo that we've put out, and that APD has put out too, because a lot of them aren't aware that Chief Medina has said we're going to own the mental health emergency aspect as long as there's no medical component. So it's always a good time to stop and educate and communicate.
Okay. Yeah. After talking with you, I was like, oh shoot. Okay. Yeah. I was like, he does not have any medical complaint, and rereading the protocol again. It's like, okay, yeah. It's like, I felt comfortable. I was like, yeah, this guy can go with APD.
Absolutely. So,
and going back a little bit on the history on this was actually under Chief Dow's administration, and it was then Chief Geyer for APD who made the agreement that there was just a redundancy in the number of resources that were going to some of our most common calls. So for us, the 32 Bravos in public spaces, we would typically have APD there to secure the scene prior to us engaging. We realized that was an overutilization of police resources, that we could safely in public spaces be able to assess those individuals and not involve APD. Second part of that agreement was that for these behavioral health calls, because they do have more extensive training, the CIT training, other behavioral health training that we don't have, not to mention the safety component of, having ways to be able to protect themselves. They have handcuffs, they have law enforcement officers who have the ability to detain, which we don't. It gave them better authority and better autonomy in running those behavioral health calls with no medical component alone. So you touched on some great points, checking the fact that they don't have any medical complaints, they haven't ingested any substances, there's no potential for overdose, they're not intoxicated, they offer a clear judgment, but they strictly want a behavioral health evaluation. They are appropriate to be able to go via APD. It don't necessarily have to go through EMS transport. So I want to just talk a little bit on that in terms of, we talked about policies and as opposed to, waving policy in each other's faces when we're on scene, is just having that dialogue with the officers. Like, there is no medical component to this, keeping it patient-centered, do your patient assessment, ask the patient, what do you want to do? And if they don't want to go by ambulance to be treated for a medical need, then they are absolutely appropriate to go via APD. We have ACS now, the Albuquerque Community Safety Department, who has offered transport for behavioral health services as well. So that is another option that can be achieved through the alarm room. We know about the MCT teams. You touched on that a little bit earlier. Law enforcement officers teamed up with behavioral health clinicians to be able to jump on some of those low acuity behavioral health calls. Those are all resources that we have. So I know this is a call that you get regularly
this
at
is
7-8.
Probably the most frequent call that we get, because
Absolutely.
There's so much gray area. We could really talk about this one all day long. Some of the main points is that a court order for evaluation, it's a police order. EMS does not honor these. It is only for the police department to honor. Where we will make an exception, we have two exceptions. Is one, if the person has a medical component. So if the MCT team has come out, we have the on-site behavioral health clinician that's determining this person needs to be evaluated by a mental health physician, and they write this court order for evaluation. This is stating that legally now they regardless if they're A&O, regardless of whatever else is going on with them, they have to go. So the two exceptions we'll make for a C-free is if there's a medical component. And at that point, the C-free is irrelevant. This patient has a medical complaint. We need to address that before we get to their behavioral health complaint. So that's where EMS comes in. The other that we'll do on a case-by-case basis is if the patient physically cannot sit in the back of a police car, or if it would cause them harm. So APD likes to, this patient's in a wheelchair. And so your patient was a great patient to say, this patient, they can stand and they can sit and they can pivot. It's not going to be harmful to them. Yeah. So this is a good time to have that dialogue with APD and, let them know that, hey, even though he's in a wheelchair, this patient's still appropriate. The patients that really we're looking for that we get C-frees on quite a bit are elderly patients. So if you have an 80-year-old patient who has dementia, who lives alone, they're an oriented person, they have a court order for evaluation, and they have severe arthritis and osteoporosis, and they have, thinking about some of these patients have physical ailments that would actually hurt them to put them on these hard plastic seats in the back of the police car. Those are patients that absolutely we're always going to do what's right for our patients, and we'll assist APD with these patients, transporting them to the behavioral health facility. Yeah. And APD should still be following, because at that point we're essentially, we're just a ride at that point. It's still APD's responsibility, so they should be following us to either caseman or UNMH mental health. And when we get there, we'll facilitate a turnover to a safe place for them, and then APD takes responsibility for that patient at that point.
Okay, I didn't know that.
There's many gray areas in this.
Wow. Okay.
We'd have a 2-hour podcast if we could talk about everything for sure, because it's absolutely, it's prevalent and it's happening quite often. And it's just, I think it's just a lack of understanding of what capabilities we have within the system. And it's not a matter of us wanting to shirk the responsibilities or pass the buck on to another agency who we know is busy, and has a finite number of resources too. But it's just for the safety of our providers has to be paramount. And then also maintaining the integrity of our EMS system to know that you can't just use ambulances and emergency rooms to serve as your behavioral health, assessments all the time. That there are specialized services and transport capable units that are able to do that and keep them out of the EMS system.
And that's one of the biggest points too, is that it's do what's best for the patient. Mm-hmm. And the patient isn't served well by going and sitting in an ER and taking resources up there that they don't need. No one's served well by that. None of the other patients, the staff. So it's really important that as an EMS system, we get on the same page. And once we've determined that you have a patient that's having a psychiatric emergency that has no medical component, at that point we let APD take responsibility for that patient, and so that they can get the right services that they need in a timely manner. And being consistent in that is so important, because a lot of times the AS will get there first and they're well-intentioned and they say, well, we'll just transport them. Yeah. And maybe APD is busy and they consent to that, but it really doesn't serve the patient well. And then the next time that this officer goes out on a call, a lot of times we'll get a call, and when I talk to them, they'll say, well, you guys did this last time, why can't you do it now? And, so it's difficult to go back and say, well, here's how it was supposed to work. I'm sorry it didn't go that way, but this is how it's going to work today. If we can, as an organization between AFR and AS, as an EMS system, if we can get on the same page, then it's really going to, our ultimate goal, it's going to serve our patients well.
Yeah.
And communication is key on scene. And I think one of the things we talk about is all of these conversations, right? You're already talking about people who are in crisis. They're already amped up. They're having a bad day. The who's going to transport them or who's not going to transport them is never a good discussion to have in front of the patient. So being professional, being respectful with the APD officer, talking away from the patient to dictate exactly who's going to take this individual to the care that they need. If you're met with resistance, again, just stop. Don't engage and call 7-8, I think is the biggest takeaway for the field providers, because what we've given is 7-8's the autonomy to make that decision. They're well versed in all of this and they understand what our capabilities are and what they aren't. So they can make that final decision of yes, it's more appropriate for them to go by ambulance, or no, absolutely not. This is strictly a behavioral health issue, and the safest and most efficient way is for them to go via ACS or APD depending on the situation. And then if we do, as kind of you alluded to, if we do decide to do the transport, then if that patient is cuffed, that officer is riding with us. If they're not going to be cuffed, then they're following behind because they still are in APD's custody. And then also, if at any point that patient does not want to be transported, then we're not bound by any law enforcement statutes. So that person we can stop, we can safely let them out of the back of the ambulance, and they can go on their way, and that still becomes a law enforcement issue.
Absolutely. And that's why it's important to get APD involved when they should be involved, so that we don't get in a weird situation where you're stopping on the street and letting a patient out and then starting all over again. The patient's not served well by that. And Chief, to reiterate what you said, is that's the biggest takeaway, is that there's so many gray areas, and we've touched on like 4 of them, and there's probably like 10 more. And so please, before a transport decision is made, if you're not sure what's the right way to go, please reach out to 7-8. And we're also getting a great response from the field officer's supervisor. Once we get their sergeant involved, they're like, hey, thank you for your response. We got it. And so there's also an education component that is happening on their side as well. So
we know how it is. It's a big organization like ours, where like leadership agreements may be made, but it takes a while for that to get trickled down to the boots on the ground. So there may not be officers that are new or just not aware of the policies and procedures. So we just want to make sure that our folks are well educated, understanding what our policies are. We don't have to understand all of APDs necessarily, but just know how we should operate on these calls and know who to contact before we just do the transport. And then, like you said, kind of talk about the next time we have that same call, somebody does it differently, then it gives everybody pause, and it's opens up,
Absolutely.
bad lines of communication. So there are caveats that we did say, we've already talked about, which is easy. The patient wants to go to the hospital, we take them to the hospital if they strictly want to be seen for a medical purpose. We did talk about behavioral health for pediatrics. I don't know if you want to touch on that real quick in the agreements that we made.
Yeah, so one of the agreements we made with APD to, again, do what's right for patients is that there's a lot of stigma around mental health. And we made an agreement with APD that any pediatric patient 12 and under that is having a psychiatric emergency, AFR will be the transport agency, not AAS, not APD, but AFR specifically for 12 and under pediatric patients, behavioral health emergency, we will be the transport agency. And our goal with that is to try to reduce some of the stigma around mental health that, these poor kids, they're having already a really, really hard, horrible time. And then to be taken to the hospital in the back of a police car, that's going to be, the thought is that that's going to be more traumatizing for them. So that's another way that we're really trying to be diplomatic and understand that this is a complicated situation. And as we work with APD to solve it, we can all be flexible and come up with good ways of doing things that's best for everyone.
Absolutely. For anybody who hasn't caught the MO2 training yet, one of the discussion points within that training is how we should engage with behavioral health patients who may be agitated at the moment. I think one of the points of direction and one of the things that the Medical Control Board changed within the guideline was our responsibility or requirement to engage with a patient who may be aggressive, may be agitated, may be amped up. The direction that's come from our department is that if a patient is agitated and you can safely assess them, try your verbal de-escalation techniques like you would normally do. If those are unsuccessful, the patient's still agitated or becoming violent, then separate yourself from the situation. That means removing yourself back to the truck, back to the station, call for APD, whatever it takes to kind of isolate that situation to keep yourself safe. There is no expectation from this department to get hands-on with an individual if you don't feel safe in order to render care. So that means, having to hold down a patient to try to get them to the gurney, utilize APD, utilize law enforcement, Bernalillo County Sheriffs as well to help assist in that. Now, there are going to be certain circumstances where it doesn't meet the criteria for them to be able to get hands-on because it is considered a use of force. And that's okay too. If they understand that we can't engage just the same way that they can engage in order to keep our folks safe, then that's just an understanding that's going to have to be, disseminated to the community to just understand there are some people that are going to have to walk away because nobody can engage them in that behavioral health crisis.
Absolutely, and that's a really important point too, Chief, is that there are many people in our community that they're normal for them is atypical for everyone else. And so a lot of these calls come in from just a concerned passerby. They see somebody, scooting in a wheelchair down the street, screaming, yelling profanities. We get there, and this patient is able to communicate with us. They can tell us, who they are, where they are. And a lot of times, apart from that, they can't do a whole lot more than that. And people want to start, forcing transport and calling out the MCT. And you have to determine, is this normal for this patient? So that's a great time to get consortium involved. They're also a great resource if you're not sure if this patient is decisional or not, if they need to be transported or not. That's another good phone a friend. Is a consortium physicians.
Mm-hmm. And a lot of times, like the certificates for evaluation, like you described, it's a clinician who's writing an order saying they have to go. We're not bound by that order, and I think you spoke to that, but we are bound by medical direction, and part of that umbrella is the consortium. So if we get our spidey senses that this doesn't feel right, or we should or shouldn't be transporting, whatever the situation or circumstances dictate, make that phone call to consortium, let them know what's going on. They're well versed in this as well, so they can help out. But I always, unless it's something medically or clinically needed at the moment, I always encourage 7-8 to be the first phone call, just because you guys have the better institutional knowledge as far, but organizations have agreed to. So I appreciate that. And that MTU, the MO2 training that we talked about, it's not to necessarily say you can never touch a patient or you're going to be held responsible or liable. The understanding is good faith judgment on what you can and should do to protect yourself first and to protect the patient second, right? So there's no expectations you're going to tackle somebody, take them down, hold them down until law enforcement arrives, because it's not what we're trained for, it's not appropriate, and it doesn't put you in a safe situation. So if you're ever backed into a corner, that's what we're talking about. We want to avoid that worst case scenario, having one of our folks get hurt by implementing some of these tactics and some of these agreements.
Absolutely, and that's a big change from how we used to do things, both us and APD. Mm-hmm. So.
And it's going to take a system change. That's why it's important to say that we have to be on the same page with Albuquerque Ambulance. So we meet with them regularly to talk about some of these things, but we're going to have to continue to push the issue. We have a quarterly meeting with law enforcement, some of the hospitals, because they're encountering a lot of the same things in terms of safety of their folks. We've started tracking the EMS assaults because we want to know how often it's happening. That way we can either target, regular offenders of EMS abuse and be able to pursue that and just have an idea of what it's going to take to keep our folks safe. So it's a great topic.
It is.
We could go on and on for hours. Any closing points that you wanted to make in terms of?
We already touched on it, but if you're having issues, if you're not sure of the right decision, please reach out to 7-8 prior to these patients being transported. Would be the best thing to do. And at the end of the day, always default with your gut of what's best for this patient.
Keeping it patient-centered, I think we can't say that enough. Good faith judgment, keeping it patient-centered. If you feel like this patient is best served by going in an ambulance, then let's do that for them. If that's what they want to do, let's do it. But if it's strictly behavioral health, there's no medical component. They don't want to sit in an emergency room. They just want to talk to somebody about their behavioral health problems. There's a lot of other resources who have agreed to help with that, so we need to make sure we're engaging them to get them the right spot. LT, and especially working in Station 12's district, you're going to see this more frequently than us. I hope you understand a lot of these policies, procedures, agreements are done with you in mind. We want to make sure that you stay safe, that the call types are appropriate, that you're going to be able to go to and be able to intervene successfully. So if you see anything or anybody out there who's watching has any recommendations that we can look at as far as interagency operations on some of these behavioral health calls, feel free to reach out. But I really appreciate you taking the time to come out and talk with us today.
Yeah, no problem. Thanks for the invite.
Awesome.
Good to see you.
And Captain Murphy, I appreciate you as well, as always. And that's going to do it for today's session. Please let us know if you have any interesting cases that you want to discuss. Submit those through SharePoint. And then if you have any questions, reach out to your 7-8 or the EMS division. And we'll see you next time. Thanks.